Good afternoon, everyone. Welcome to the today's session. I request to Priyanka. Please start the session.
Good afternoon, everyone. COE JJ Hospital welcomes all participants to today's RDLS session. Today's topic is adherence to ART, and the speaker is Dr. Priya Patel, ma'am, Deputy Program Director and Alternate Nodal Officer at JJ COE. We welcome you, ma'am, for today's session and request you to start the session. Thank you.
I thank ITEC for having this session again, because last time we were not able to complete our session objective of adherence to ART. So today we will discuss about adherence to ART. So coming to adherence, the extent to which a person's behavior, that is the taking of medication and following healthy lifestyle, including a healthy diet and other activities, corresponds with the agreed recommendations of the healthcare providers. So that is the WHO definition of adherence. So it is very important to assess a patient's ART readiness, and that is the first step to successful ART adherence. So basically, when we want to start the patient on ART, we should be assessing the patient's ART readiness. Now, why it is important? Normally, if we have a medicine OPD or any OPD where we are giving treatment, we never discuss about adherence or separate any session is not there. So why this is a difference, that for ART, we need to have a ART readiness assessment, and why it is the first step to successful ART adherence. That is very important. See, we take this adherence counseling very lightly, and I have discovered this thing through my SASEP encounters. So many times I get SASEP referrals, and the SASEP referrals are flooding, literally flooding our COE in HIV, and I'm really shocked to see the extent of patients who are failing on TLD regimen, the referrals, and the duration of TLD is hardly 1 year, 2 years, and then I am getting referrals that the ART has failed. So we, with our experience, whatever experience I have, in our ART, in our COE also, we had this patients with 30 patients who were failing on third line on dolutegravir based regimens, and we did their viral loads, they were high. So everywhere when we selected those 30 patients, the viral loads were more than 1000, and the adherence was referred to us, and to it was assessed by even by the counselors and medical officers. It was written on paper as more than 95%. But actually, when we tested their samples and found out about the susceptibility testing, we found that in almost more than 90% patients, nobody had any resistance, and they were susceptible to dolutegravir. And then again we went back, we called each and every patient, we discussed with each and every patient whether they were really taking the medications, and that time many issues came out, and actually the patients were not really taking the medications properly, and the adherence was not 95% as it was referred initially. So this is that is for third line. But even with first line, when we are giving these medications, it is very important for the counselors as well as the medical officers to talk to the patient and see whether they are ready and how is their attitude, whether it's positive attitude for their disease as well as for the treatment. That is very important. So sometimes the patients are having a lot of anxiety about the side effects. They are not very willing to take the medication. Now, many times what happens is the patients are detected incidentally. That is, they want to go for some surgery, and then the blood test is done and it comes positive. So they don't have any symptoms. And so they feel that I don't have any symptom, I'm not sick, why should I take this treatment? And that too, they are supposed to take it every day and lifelong. Now imagine, suppose we are told we are not feeling any symptoms, we are feeling healthy, and somebody says, no, we have this disease and you take this medication daily. So then you don't have the drive to take it regularly. I have seen patients who I had one patient, I will give you the example. This female patient was having severe opportunistic infections when she was referred to me initially. She had severe TB, which was spread. And then she also had cryptococcal meningitis. And she suffered like anything when she was almost on the deathbed when she was diagnosed to have HIV. So then we admitted to her, we gave her the treatment. She gradually recovered from all her opportunistic infections. Her TB also healed. But because she had really experienced this disease severity, she was so adherent. Even now she comes to us after this story was around 2005 or 6. So that time, she was started on ART, and now also all these years she has taken it so regularly, and she still is on first line ART. She's continuing to be on first line ART, and she is very regular, and her adherence is excellent. Why? Because she had, almost touched the death, and so she knows the importance of taking the medications. But this is not the case with our patient now today. Most of our patients are not having any symptoms, and so they don't know the relevance of taking ART. So here is our job, how much we are going to convince them to accept ART. So that is the patient. So we have to convince them. You have to tell them, if the patient has some scientific background, you can, show that viral multiplication, some, picture, take help of this other, aids, and, explain that what is this HIV infection and how the virus is spreading in the immune system, how it is reducing the immune system. So though the patient does not have disease externally, inside the immune system is being weakened. So all those things we can tell in the initial period, so that the patient is now convinced that he has to take the treatment regularly, and it is a lifelong therapy. So this cannot happen only one session of counseling. Sometimes if the patient is really not psychologically accepting, we may have one more session. So before we begin, we cannot just force the patient ki ye lo dabba lo or khao. That doesn't work. So patient is not going to take it. Patient may take it initially and just then throw the pills away. That is what is happening. So that is why adherence counseling is very, very important. And so when we are starting a patient on ART, that time we need to spend more time. If we invest that time in the patient, then the outcome will be successful and the patient's adherence will be good. So that's why I'm told this at length, that assessing a patient's ART readiness. And for that ART readiness, we have to give some information to the patient about HIV disease, how it spreads, and how it is attacking the CD4 T cells. All that information we may give to the patient, and then the patient can be ready to take the treatment. Now for ART, a high level of sustained adherence is necessary to, first of all, suppress viral replication and improve immunological and clinical outcomes. So the main goal, why we are giving the ART, to suppress the viral replication, and this will improve immunological and clinical outcomes. Secondly, decrease the risk of developing ARV drug resistance. That is very important. If the patient is going to develop ART resistance in first, second year or third year on first line ART, then the future, the scope is very less, because we have limited options of drugs. Okay, so we don't have unlimited drugs ki abhi kitna, third line resistance ke baad fourth line, fifth line, seventh line, 10th line, aisa nahi hai. We have only 3 limited options. It's limited, we had discussed it in the last class. Protease inhibitors are there, NRTIs are there, and integrase strand inhibitors are there. So with this limited drugs, optimally the patient should continue for at least 1 or 2 decades properly. So if that happens, then it is a successful treatment. So we need to decrease the risk of developing ART drug resistance, and that's why also we need to invest our time in doing proper adherence counseling. And thirdly, to reduce the risk of transmitting HIV to others. So if somebody has a very low or not detected viral loads, so to say, so a virologically suppressed person is not, less likely to transmit the patient to his sexual partner. Then adherence should be assessed and routinely reinforced by everyone in the HIV care team at each of the patient's visit to the ART center. Now, this is very important because somebody, so it's a team. The ART center is a team. The patient is going to the counselor, the patient is going to the medical officer, patient is also going to the pharmacist. So somewhere then the staff nurse also may talk to the patient. So, if everybody is making a point to routinely reinforce, then the patients also understand the relevance of it and importance of this adherence. Otherwise, it is all very casual. The patient be casual hai, and the people are so busy. Abhi, the whole team is busy. Usko pucha hi nahi, humne assume कर लिया कि patient ने खाया है. So then it is going to be missed. So that's why it has to be assessed and routinely reinforced. So medical officers also should be asking, not only the counselors, and many times the counselors will just ask because they say कि हाँ हमारा ये patient अभी बहुत साल से खा रहा है, उसको सब मालूम है, हमारा विश्वास का patient है. तो ऐसे हमको प्रिज्यूम नहीं करना है. काउंसलर्स ने हमेशा क्रॉस चेक करना है और पिल काउंट हम ये एंड के ये लेक्चर के अंत में पिल काउंट कैसे कैलकुलेट करना है वो देखेंगे. तो पिल काउंट करके हमको एग्जैक्ट एडहेरेंस कैलकुलेट करना है. तो ये बहुत इंपॉर्टेंट और जरूरी है. Studies indicate that more than 95% of adherence is required for optimal viral load suppression. Now, this is very important that for optimal viral load suppression, more than 95% of adherence is required. So, lesser degree of adherence is often associated with virological failure, and the viral load is not properly suppressed if there is a lesser degree of adherence. Now, what is the difference between compliance versus adherence? Adherence differs from compliance. Compliance is the extent to which a patient's behavior matches the prescriber's advice. So, suppose the prescription contains for a diabetes patient, diabetic diet, then exercise, and then the diabetic medication. So, if the patient is doing everything properly, then you know that he is compliant. So compliance implies patient's obedience to the physician's authority. Means whatever the physician is saying, compliance means that the patient's the patient, if he is obedient to the physician's whatever instructions, then we say that he is compliant. But what is adherence? Adherence signifies that the patient and physician, they are one team together. They collaborate to improve the patient's health by integrating the physician's medical opinion and the patient's lifestyle, values, and preferences to care. So what does this mean? That here it is a teamwork. So to help the patient to be adherent to the medication, the physician will be involved and he will integrate, he will ask about the patient's lifestyle, what are his preferences, at what time it will be suitable for him to take the medications, and whether he has involved some family members, he has disclosed his disease to some family members who will then able to support him. So all that detailed, inquiry and the involvement of the physician to into this whole, not only just taking the medication, but how the patient is coping up with the disease, everything. So that means there is an active role of the physician. It's not that the physician is just prescribing and the patient is obeying. So if that will not work, because here ART, again, it's a full lifelong medication, lifelong adherence. And just imagine we are in the patient's shoes. Suppose we are taking some antibiotic course for 10 days. So in that 10 days of antibiotic course also, sometimes we tend to miss it for 2 days. So if that is the case, for a 10-day antibiotic course, then for the patient, we have to imagine that he has to take it every day at the same time without forgetting, lifelong. So it is really a challenge. If we understand this patient's problem, then we become more we have more sympathy and empathy for the patient's issues, and then we will really talk to him and sort out what are his obstacles in this adherence. And that, team approach is going to help the patient to really adhere to the medication day in and day out. So it is very important, again, as I said, to invest time. Ask whenever we are starting the ART initially, that time itself, please ask, because we have done this exercise when I am taking SASEP for a patient. The patient is, apparently failing on a dolutegravir TLD regimen. And then we had this tele-SASEP. And when I asked the patient, "Aap kya kaam karte hai? Kitna baje goli khate hai?" And then sometimes that timing of the tablet is, he is at his workplace when he is supposed to take the tablet. And at the workplace, he may not be able to take the tablet in time. And then that's why it gets missed. So all that, so we should not do it when the viral load goes high. We should do all this exercise right in the beginning. Ask the patient proactively what time is suitable for him, and we have to help the patient to plan our suitable timing. So that is very important. Then coming to pregnant and postpartum women. So pregnancy related conditions such as nausea and vomiting may negatively affect treatment adherence. And again, I'll give you all one example of our own ART center where there was a young mother. So she had a transmission from her mother. So it was a mother to child transmission. So this young lady, her mother was also a PLHIV. And then later on, this girl grew up and she was married, and now she herself was pregnant. So at that time, so before pregnancy also, her adherence was not so good. And now she was pregnant. So she was counseled multiple times. So the medical officers personally counseled her every time, and the counselors were talking to her. But still, when we saw her viral load, we were really shocked that in spite of all this counseling by everyone in the team, her viral load was more than 1 lakh. And then they got frustrated. So then they told that this is the situation. She's just not taking the pills. So then I also talked to her, and I found out. So after a lot of questioning, then she confided that why we asked. I asked her why you are not taking. So finally she told me कि उसका smell आता है. So that was the reason why she didn't want to take it. So then I had to, really counsel her a lot. I told that you have to think of your baby. If your baby is infected, then it will that baby situation will be like you only, because unfortunately you had the disease. It got transmitted from your mother to you, and the same situation will happen to your baby also. And so you should have this, we will sort it out for that nausea and all. We'll give you some treatment, but please take the pill on that time. All that. So a lot of counseling, again we have to do regarding on this aspect. And then she agreed that yes, for the sake of the baby, this small inconvenience I'll tolerate. And we also gave her some medications to combat that nausea. And after that 1 month of ART, her viral load was really suppressed. It was TND. So, all these challenges are there. So again, the key thing is our involvement as a team in the patient and how we are able to counsel and explain to them again and again. So other challenges during this period also include coping with the diagnosis. So if the patient is diagnosed for the first time during ANC period, then she has this very shocking news, and she has to cope with the diagnosis of HIV infection, because that woman learns about their HIV infection during the routine antenatal screening. So we should again support her, give her all our support to explain to her that yes, though it is a lifelong, it's a disease, but still the treatment is there and she needs to take it properly. Again, there are a lot of concerns in her mind about ART affecting the health of the fetus. So we have to approach that. We have to address those concerns. We have to explain that all these medications are really safe, and if she takes them properly, it is going to prevent the infection to her fetus. So all that we need to discuss with her properly. The pill burden also, that concern may be there. The number of clinic visits during pregnancy. So all those things, fear of disclosure of HIV status to partners. So that can be a sometimes constraint, especially if the partner is negative, and long waiting times at clinics. So these are again concerns, because They are not willing to come because again, the main thing here is they are just asymptomatic. It's all on routine in screening. It has been detected. So they don't feel they don't know so much that HIV will suppress the immunity. They will get opportunistic infections. All that they are not knowing. So what they are thinking primarily is their inconvenience in going to the clinic and doing all this activity. So the key thing is telling them about the severity of this disease. If they don't take treatment, what can happen? We may show them the pictures of actual patients. We may show them some actual patients who have not taken treatment and now they are, what is their state. So if we show them all that and if they explain to them, and we need to reinforce that information every time so that they really understand the gravity of their disease. That is very important. Secondly, we should compliment them if they are taking properly the treatment. If their viral load is suppressed, we should appreciate that. And if they sometimes don't take treatment because of something, we need not put them in the how we are dealing with an accused. All of them pouncing on the patient, shouting at them, "Arey, goli nahi khaya barabar se, aapko free mil raha hai, fir bhi aap nahi le rahe." So that kind of approach, then they will never confide with us next time. If we are shouting at them and if we get angry on them, if they are not taking the treatment, then they will stop telling us only that they are not taking. Then every time they will say कि हाँ गोली लिया है बराबर. They may throw the tablets. आपको empty डब्बा दिखाएंगे. आपका pill count आपने किया, empty डब्बा है तो that means सब tablets लिए हैं. तो क्या होगा? आपका adherence तो 100% दिखेगा on paper, but actually patient आपसे डरता है, वो आपसे सच बोलता नहीं है. तो ये हो सकता है. तो उनको पेशेंट को आरोपी के कटघरे में नहीं रखना है कि हाँ आपने क्यों नहीं खाया. आपको उनसे एकदम हमदर्दी से थोड़ा सा पेशेंटली बात करना पड़ता है. गलती पेशेंट की होती है, लेकिन वो गलती की सजा हमने नहीं देनी है. हमें वो गलती क्यों हुए वो देख के उनको सुधारना है. सो 90% टाइम अगर गलती क्यों हुआ है वो हमको उसके सर्कमस्टेंसेस समझे. ये काउंसलर्स के लिए मैं स्पेशली बात कर रही हूँ. तो अगर आपका रैपो अच्छा है पेशेंट के साथ, आप अच्छे से बात करते हैं, तो ये पेशेंट आपसे अगर प्रॉपरली कन्फाइड करेंगे क्यों नहीं लिया, क्या इशू हुआ, तो वो इशू हम एड्रेस कर सकते हैं. और या आपके मेडिकल ऑफिसर को जाकर रिपोर्ट कर सकते हैं कि ये इश्यूज है ये पेशेंट के, इसके कारण वो गोली नहीं खा रहा है. तो फिर मेडिकल ऑफिसर भी उसमें ध्यान देके उसमें इम्प्रूवमेंट ला सकते हैं. क्योंकि ये सब हमारा जो उपक्रम है ART सेंटर का, वो पेशेंट ने बराबर से ट्रीटमेंट लेने के लिए ही है. और अगर वही चीज नहीं हो रही है तो ऑन पेपर सब परफेक्ट दिखेगा. ऑन पेपर हम 100% अडेरेंस लिख रहे हैं, बट एक्चुअली पेशेंट को फायदा नहीं हो रहा है, उसका वायरल लोड बढ़ रहा है. तो ये हमें बहुत इंपॉर्टेंट है कि पेशेंट से बराबर से जो बोलते हैं डायलॉग, संवाद साधना है. तो अगर हमारा संवाद अच्छी तरह से हुआ तो पेशेंट हमको बताएंगे कि क्या हुआ, क्यों नहीं खाया है गोली. Again, adolescents living with HIV. So they are I have seen so many adolescents myself who are not taking proper treatment. So what are the adherence challenges faced by adolescents? A potentially large pill burden if they are treatment experienced. What happens is they are taking the treatment right from sometimes after their birth, from their early childhood. And so eventually by the time they are adolescent, coming to the adolescent age, they are already on second line therapy or third line. And so there is a large pill burden. Then there is a stigma and fear of disclosure. So they don't want their friends to know of their disease. So that is a stigma on them in their minds. And they feel that their friends will desert them or their friends will not accept them if they disclose the disease. So that is very important. And that's why that may play a major part. So if they feel if I'm taking the medication, my friends will know. And so they don't want to take those medications. Then some adolescents will have concerns about safety of medication, and then the adverse effects of medication may not be, so they don't now they are young adults now, they are adolescents, so they tend to rebel. So if the medication is causing a lot of adverse effects, again they feel that they are better off the medication. सब पेशेंट्स ऐसे बोलते हैं कि मेडिकेशन जब हम गोली नहीं खाते हैं ना तब हम अच्छे रहते हैं, गोली किया तो तकलीफ होता है तब बीमार पड़ते हैं. So if that's why as a ART team we need to ask them व्हाट अबाउट द एडवर्स इफेक्ट्स, और अगर एडवर्स इफेक्ट्स है और सिग्निफिकेंट है तो हमको उसको ART को चेंज भी करना चाहिए। सिर्फ उधर काउंसलिंग करके नहीं, गोली खाओ, कुछ भी करके गोली खाओ, ऐसे होके चलता नहीं। अगर पेशेंट को एडवर्स इफेक्ट है तो नहीं खाने वाला गोली, तो उसमें भी आपको ध्यान देना है कि क्या एडवर्स इफेक्ट है, और काउंसलर्स ने एडवर्स इफेक्ट समझा तो वो जाके मेडिकल ऑफिसर को बताना है कि ये एडवर्स इफेक्ट के कारण ये गोली नहीं खा रहा है, सो देन द मेडिकल ऑफिसर कैन एड्रेस द इशू। Then peer pressure and perceived need to conform. So peer pressure is there. So that's why they don't want to be different from their friends. They don't want to be seen as taking this medication. Sometimes not remembering to take medication. They may forget easily because teenagers and adolescents, they have so many other activities. They are into education. They are going to college. They may go on having classes. So they may not remember. So again, the family should be involved in that. It is our duty as a counselor or medical officer to see that the caretakers are really monitoring the adolescent at home. The adolescent may have an inconsistent daily routine. He may not get up at the same time daily. So if we have fixed a morning time, so sometimes he's getting up at 6, sometimes he's sleeping till 10 o'clock, then he will miss the morning dose. So that's why again the timing of the tablet should be fixed as per his proper routine, and we have to address the issue of inconsistent daily routine in that also. Then the adolescent may have depression and substance use. So that also can present challenges. So sometimes they are, taking alcohol or drugs, or they may be depressed. So that can cause problems. And I remember one adolescent boy, it was I think adolescent boy who used to throw all the tablets outside the window. He used to not take only any tablet, and always his viral load used to be high. So we were thinking whether he's failing, but and always in front of everybody used to say, "Nahi, goli khata hu." But then with lot of dialogue, we found out that he was throwing all the tablets, and then we found out that he didn't like again the smell of the medication, and there were some side effects. So that had to be addressed. So whenever you have an adolescent, a person, we must anticipate all these problems and properly, talk to that patient. Again, at Science PCOE, there is a proper adolescent. There is a special counselors for adolescents. So if you have an adolescent patient and really you are having some issues and the patient is not confiding in you, we may refer for this adolescent counseling there also. Then coming to infants and children, adherence among children is again a special challenge. These include the limited choice of pediatric formulations, poor palatability of liquid formulations, high pill or liquid volume burden, large pill size, frequent dosing requirements, dietary restrictions, loss of primary caregiver. So primary caregiver is parents. So if they are not there, then some grandmother, grandfather is there who is taking care, or the uncle who may be busy. So, that's why that again can have issues. Difficulty in swallowing tablet and adverse effects. So all that may affect adherence in them also. So now coming to counseling for treatment preparation and adherence. तो counselors के लिए बहुत important है कि आप अच्छे से संवाद साधना है, establish rapport and a relationship of trust with the patient. तो patient का आपके साथ अगर अच्छा rapport हुआ तो patient आप पे विश्वास रखेंगे, और ये बहुत बड़ी important पहली चीज है जिसके कारण patient adherence करेगा. So provide necessary information and guidance. ये बहुत important है कि HIV infection क्या है, इसमें क्या होता है प्रॉब्लम, तो ये सब आपको नेसेसरी इंफॉर्मेशन देना है. एनकरेज peer participation and help identify treatment support persons. तो ये बहुत ही इंपॉर्टेंट है. If we encourage peer participation and identify treatment support person in the family, then that family person will see to it that the patient is really taking the adherence, taking the medication. Encourage disclosure to an identified family member. This is again very important. I remember one patient, they had not disclosed, that couple, husband and wife, had not disclosed to their in-laws at their home. So the mother-in-law didn't know, and that's why the daughter-in-law was not taking treatment properly, because she didn't want to take it in front of her mother-in-law. So later on, then we talked to them, and then it was disclosed to their in-laws, and after that the adherence improved. So encourage disclosure to an identified family member. Family members, if they know, then the pressure is much less, and the adherence also improves because of their cooperation. Encourage positive living and positive prevention. So positive living means they accept, they know that this is a lifelong treatment and they take responsibility of their health and they are taking properly the ART. So their lifestyle is also based on that, a healthier lifestyle, taking ART properly. So that is encouragement of positive living and positive prevention also. Provide information about cough hygiene and for TB prevention, that is important. Perform 4S symptom screening. Develop an individual treatment plan. This is very, very important. So ask the patient what job they are at and who is their family member who is going to support. So all that. So individual treatment plan for that patient. Fitting the ART into the patient's lifestyle. This is very important. So please do that exercise for every patient new patient you are starting. Try to fit that ART into that individual, whatever timing is suitable for that patient, and daily events and identifying treatment reminders. How you are, mobile mein reminder rakhna hai, alarm rakhna hai. So how treatment reminder, all that we have to see. Assess patient's readiness for and commitment to ART. Readiness to commence ART may be assessed by the following: ability to attend ART center regularly and not miss appointments, ability to take OI prophylaxis like cotrimoxazole, and ability to complete the full course of TB therapy if the patient is having co-infection with TB. Then list barriers to adherence and develop strategies to overcome these barriers. Ensure adequate understanding of ARV adverse drug effects. There should be strict adherence to treatment. Adherence to recommended regimen should be more than 95% to avoid development of ARV drug resistance. If patients have difficulty in adhering to regular doses, reinforce adherence counseling. Enlist community outreach teams and peer support groups of PL-HIV as appropriate, and inform that the treatment is lifelong. Then timing of drug intake is very critical. For example, drugs taken twice daily must be taken every 12 hours. Whenever I take these SASEP meetings, ask regarding these timings, they say timing miss hota hai. So please ensure that the patient is taking it on time, proper at interval of 12 hours for twice daily and 24 hours for once daily tablet. Missed doses can be taken up to 6 hours later in a twice daily regimen. If more than 6 hours elapse, skip the dose and take the next normal dose. If the pill of a once daily regimen of TLE or TLD is missed, then it should be taken as soon as the patient remembers within 12 hours. ये सब information हमको patient को दे के रखना है. Dietary requirements with ARV drugs. Some drugs are taken with food, some on an empty stomach. Fatty foods need to be avoided before some drugs, and some require an increased intake of water. Now for our first line ART TLD, it is preferable to take it with food because food will enhance the absorption of TLD, both food as well as dolutegravir. So you can tell the patient that after the meals you can take. People on ART need to continue using condoms, so that we have to tell, and practice safe injecting drug use. Other medications including the herbal or traditional products may interact with ART, so it is not to be recommended. You have to ask the patient if they are taking such products, and if they are, then you tell them not to take. Patient needs careful counseling about which medications are allowed and which are not with their ART. So for dolutegravir, we know that multivitamins and antacids, they have interaction. So the timing of those multivitamins has to be, there has to be a gap at least 6 hours after DTG. And some antiepileptics are also not allowed. Okay, so that we should ask about all these medications. Regular clinic attendance for monitoring of efficacy, side effects, and adherence is essential. Now, step 2 is the counseling in one or more individual sessions. Help the patient explore his or her feelings. Many patients are preoccupied with problems related to family, job, relationships. So they cannot focus on strict adherence. और उनको इतना importance भी नहीं समझता है. सब negative feelings रहते हैं. So they cannot focus on strict adherence until negative feelings about all these problems are sorted out. So we need to help the patient in sorting out all that. Many have no private place to store their medicines, are not able to take them in privacy. Not wanting others to know their HIV status is by far the most common reason for poor adherence. So please ask your own patients how they are going to have this, and explain to them. Patients must be realistic about whom to confide their HIV status in and how to tell them. Check for any financial difficulties the patient may be experiencing. So they may not have money to travel to the ART center. So in that, we need to help patients develop secondary support system for themselves. Step 3 is solving practical problems and creating a treatment plan. So this is very important. Where will the ARV drugs be stored? So that you have to discuss with the patient and sort it out. At what time will they be taken? So it should not be that he should be on the job. At least if he's at home, he is able to take. So find a suitable time according to his job timings. How will the patient remember, or who will remind him or her to take the medication if he or she forgets? So please again have a plan ready. If he is forgetting at that time, who will be in the family to remind? What will be the patient doing if his or her normal routine is interrupted? A time should be agreed upon to meet or telephone the patient within a few days of starting ART to discuss any problems. And if patients cannot keep the appointment, counselors should make phone calls and or arrange home visits through CSC. So this is the checklist, very important. Please have this checklist on your table. सब counselors ने ये checklist आपने table पे रखना है, and सब medical officers they should also have this checklist. So on time pill pickup. So if the patient is coming regularly on time for the pill pickup, then you know that the adherence is good. Number of doses missed since the last visit. Whether doses are taken at the correct time interval, that is very important. If not, ask about delay in hours. Reasons for missing or incorrect dosing or non-adherence. Then if you find out the reasons, then we will guide them. Timings and dosage of concurrent medications. Now this is very important, this calculating adherence. So please see the formula. Adherence in percentages, total number of pills that patient has actually taken upon total number of pills the patient should have taken in that period into 100. So this is equal to number of pills given to the client. हम जो डब्बा देते हैं उसमें कितने pills रहते हैं हमको मालूम है. So number of pills given in that डब्बा minus number of pills balance in that bottle. So हमने 30 गोली दिए और अगर बचे 2 है तो क्या होता है, 2 बच गए. और number of pills that client should have taken 2/30. So that is the adherence. अभी examples दिए इसमें. TLD single pill daily. Number of pill balance is 9. Suppose patient डब्बा लाता है उसमें 9 pills बाकी है और patient returns on 28th day. तो 30 दिन का दिया है लेकिन patient 28 दिन को ही आ गया. तो adherence calculation कैसे होगा? दिए थे कितने हमने 30, उसमें से बचे हैं 9, तो 30 - 9 डिवाइडेड बाय पेशेंट 28 दिन को आया है तो उसने कितने खाने चाहिए थे, 28 खाने चाहिए. सो 30 - 9 डिवाइडेड बाय 20 into 100 इज 75%. तो इतना इसका adherence हो गया 75%. अभी अगर 2 pills 2 टैबलेट के डब्बे हैं, सो TL का डब्बा और ATVR, तो TL once a day, ATVR once a day. Now patient has returned on the 32nd day. 30 दिन की गोली दी है लेकिन पेशेंट आया 2 दिन लेट. तो पिल बॉक्स में रिमेनिंग टैबलेट्स TL के नील है और ATVR का एक ही है. तो TL का एडहेरेंस कैसा है? अभी टैबलेट्स 0 बचे तो 30 - 0 डिवाइडेड बाय 32 into 100. So that is 30/32 into 100, that is 94% for TL. And ATVR का एडहेरेंस 30 - 1 क्योंकि एक टैबलेट बचा था डिवाइडेड बाय, लेकिन उसने 32 खाने चाहिए थे क्योंकि वो 32 डे पे आया है, तो डिवाइडेड बाय 32 into 100, दैट इज 29 डिवाइडेड बाय 32 into 100, दैट इज ओनली 91%. तो देखो टैबलेट तो एक ही बची है दिख रही डिब्बे में, लेकिन ये पेशेंट का एडहेरेंस 91% है. तो ऐसा नहीं है कि एक ही टैबलेट खाई नहीं तो उसका एडहेरेंस मोर देन 95% हमने आंखें बंद करके लिखा. प्लीज आप कैलकुलेट करके देखिए तो आपको पता चलेगा. अभी इसमें और एक मैं आपको एक उपक्रम देती हूँ. अगर सिर्फ पेशेंट बोला, उसने डब्बा नहीं लाया है, मे बी वो बोला कि मैंने सिर्फ 2 दिन गोली मिस की है, तो आप कैलकुलेट कीजिए कितना होता है एडहेरेंस. सो कैसे होगा? 30 माइनस डिब्बे में गोली 2 बची होंगी तो 30 - 2 ओके डिवाइडेड बाय 30 into 100, तो कैलकुलेशन होता है 93%. तो अगर सिर्फ पेशेंट 2 ही दिन महीने में गोली भूला है TLD का तो फिर भी एडहेरेंस सब ऑप्टिमल हो गया. यानी अगर पेशेंट का 95% के ऊपर एडहेरेंस आना चाहिए तो एक आधी गोली वो मिस कर सकता है. तो ये अगर आपको एक बार समझ गया तो आप पेशेंट को बोलना है कि एक भी पेशेंट मिस नहीं करना है, एक भी गोली नहीं मिस करना है, तो कहीं तो उसका 95% के ऊपर एडहेरेंस आए. यू हैव टू इंसिस्ट कि he has to take each and every tablet. You cannot just miss the tablets, because even if he misses 2 tablets per month, the adherence is suboptimal. Whenever a combination of two separate drugs is given, calculation has to be done for the individual tablet, and whichever adherence is lower, that has to be considered for reporting purpose as overall adherence. Here, the overall adherence in this patient is 91% because ATVR adherence is 91%. So I hope now actually please, this is my request, सब काउंसलर्स को रिक्वेस्ट है कि एक्चुअली आप पिल काउंटिंग करना और एक्चुअल एडहेरेंस काउंट कीजिए प्लीज। ऐसे ही आंख बंद करके पेशेंट पे विश्वास करके पेशेंट बोलता है हाँ मैं खा रहा हूं, मैं एक भी दिन गोली मिस नहीं किया तो लिखा आपने 100%, ऐसा मत करिए। पेशेंट से बात करके उसको इंसिस्ट करिए, उन्होंने खाली डब्बा लाना है, उसमें कितने पिल बचे हैं देखने हैं, और ये एज पर दिस कैलकुलेशन प्लीज काउंट। And all the medical officers, please encourage, please explain to your own counselors. Please, I think all the medical officers must have understood this. So please again share with your counselors and teach them this method. It is very easy. Once they know this, then they will do it properly. So let the adherence be actually calculated and not just assumed. Thank you.
Thank you. Hello everyone, Namita.
Thank you, ma'am. Requesting all participants to ask any questions regarding these sessions or can use the chat box. Now you can unmute yourself. ARTC YCM. Dr. Suryakant, please ask.
ART सेंटर इचलकरंजी मधून बोलतो मॅडम.
हा सर बोला.
IGM मधून. आमचं एक पेशंट आहे सम्यक कांबळे म्हणून.
बोला सर, आवाज येतोय.
हा, मग त्याचा ऑन एआरटी सप्टेंबर 2021 ला ऑन एआरटी झालाय. त्याचा पहिला व्हायरल लोड केला 68,282 आहे. त्यानंतर स्टेपअप करून परत आता 4,041 आलाय. हॅलो.
हा सर बोला तुम्ही पुढे, आवाज येतो आहे.
आणि परत त्यांचं EAC केलं आम्ही परत, आणि त्याचा रिपोर्ट अजून यायचा आहे. मग असे पेशंट मॅडम जर कोणी असतील ज्यांचं वय कमी आहे किंवा आता रिसेंटलीच 1 वर्ष झालं त्यांना ऑन एआरटी आपण घेतलंय, असे पेशंट आपण EAC किती वेळा करू शकतोय?
मॅम प्लीज अनम्यूट युअरसेल्फ. प्रियंका.
हा, ऐकू येते आता सर? हॅलो.
आवाज येतो.
तर जेव्हा आपण EAC करतो तर EACच्या 3 महिन्यानंतर आपण व्हायरल लोड रिपीट करतो, बरोबर? तर EAC केल्यानंतर प्रत्येक त्या 3 महिन्यातल्या प्रत्येक महिन्यातला अडहेरन्स मोर देन 95% आला पाहिजे, म्हणजे आपलं EAC सक्सेसफुल झालंय. समजा तसं नाही झालं, समजा ते फाइंड आउट करायला लागेल खरंच की त्या 3 महिन्यामध्ये बरोबर ते पिल्स किती उरले आणि मग ते ऍक्च्युअल पेशंटने किती पिल्स घेतले डिवायडेड बाय त्यांनी किती घ्यायला होते, जो काय फॉर्म्युला आहे तो तसं कॅल्क्युलेट करून बघा. आणि प्लस पेशंटला इंडिव्हिज्युअली विचारा. पुष्कळदा काय होतं ना, पेशंटला त्याचा रेलेव्हन्स माहित नाही. आता त्याला वाटतं की 2 गोळ्या विसरल्या असतील समजा महिन्यातनं एकदा, महिन्यातनं 2दा, तर त्याच्या दृष्टीने तो अडहेरन्स आहे. तो म्हणतो की नाही मी सगळ्या घेतल्या, तो कदाचित सांगणारही नाही. आपण पिल काउंट परफॉर्म केलं तरच आपल्याला कळतं. तर त्याच्यामुळे पेशंटच्या आपण म्हणण्यावर विश्वास ठेवतो. तर आता ह्या उदाहरणामध्ये काय आहे की तुमचं EAC केल्यावर जो 68,000 वरून 4,000 आला,
हा.
त्याचा अर्थ त्याचा अडेरन्स वाढला पेशंटचा.
हो.
आणि त्या इम्प्रूव्ड अडेरन्सच रिफ्लेक्शन आहे की व्हायरल लोड कमी झाला. मग ह्या केसमध्ये आपण घाई नाही करायची. सारखं सारखं त्याला रिएन्फोर्स करून काउन्सिलिंग करून आपण 2-3 वेळा सुद्धा ESC करून करू शकतो.
हो चालेल मॅडम.
हा,
थँक्यू.
एक्सक्यूज मी मॅडम, डॉक्टर दीपाली फ्रॉम केजेस सोमय्या.
हा,
आताच्या या केसमध्ये तुम्ही म्हटलात ना की आपण 2-3 वेळा ESC करू शकतो, पण
हा.
आता मी त्याचं ESC पहिलं केलेलं आहे, त्यानंतर मग मी त्याचा व्हायरल लोड केला. आता तो 4,000 आला समजा या एक्झाम्पल मध्ये, तर आपण लगेच त्याला कंटिन्युअस लगेचच ESC 3 महिन्यांची करायची का काही ब्रेक ठेवून नंतर मग ESC परत सेकंड
ब्रेक
घ्यायचा?
देऊनही करू शकतो, ब्रेक देऊन करू शकतो, काही हरकत नाही. कारण इथे
पण
आपल्याला
लगेच करू शकतो का आपण? लगेच करू शकतो का? व्हायरल लोड जसा 4,000 आलाय तर मी सेकंड ESC ला जाऊ शकते का लगेच?
सेकंड ESC ला गेलेलं बरं. कारण आपण जे ESC करतोय त्यांनी त्याचा अडेरन्स म्हणजे रिइन्फोर्स होणार आहे.
राईट
आणि
राईट.
या उपक्रमाने पेशंटला समजतं की बघ, दिसतं त्याच्या डोळ्याला की हो,
हा.
आपण नीट गोळ्या खाल्ल्या, मग व्हायरल लोड कमी झाला. मग परत
Right.
तुम्ही सेकंड ESC केला आणि 3 महिन्यांनी व्हायरल लोड सप्रेस्ड आला, तर पेशंटला
Exactly.
समजून जाईल. इट इज फॉर
बरोबर.
शोईंग द पेशंट. कारण
येस येस.
कसं आहे, दॅट रिइन्फोर्सेस हिज ड्राईव्ह टू टेक द टॅबलेट्स प्रॉपरली. आपण समजावून
Exactly.
सांगू शकतो. कारण
Okay.
काय होतंय की हे मी खूप फिनॉमिनन खूपच कॉमन झालंय की TLDच्या याच्यावर 1-2 वर्षात असे व्हायरल लोड हाय काय येत आहेत, कारण लोक नाही घेत आहेत गोळ्या. आणि इव्हन नॅशनल लेवलवर हा इश्यू डिस्कस झाला होता आणि त्यांनी एक स्टडी पण केली होती नॅशनल लेवलवर, जी त्याच्यामध्ये असं की ज्यांचे TLDवर अपॅरेंटली असे फेल झालेले त्यांना सगळ्यांना ESC केल्यानंतर नंतर मग परत टेस्टिंग करण्यात आलं आणि त्याच्यात ते व्हायरल लोड सप्रेस झाले होते.
Very good.
It is not that it is resistance is causing. This is not virological failure in 1 year or 2nd year. You
No.
should have a high index of suspicion की patient is not having proper adherence.
बरोबर.
आणि पेशंट सांगणार नाही. पेशंट कधी कधी काही पेशंट तर बिलकुल सांगत नाहीत. तर खूप
Right.
आपल्याला अगदी म्हणजे चिकाटीने त्यांच्याशी रॅपो हे करत ESC करत राहणं हा त्याच्यावरचा उपाय.
येस मॅडम, थँक्यू सो मच मॅडम.
हॅलो मॅडम.
हा,
डॉक्टर जाधव बोलतो मॅडम, मी उस्मानाबाद ERT सेंटरवरनं.
हा बोला सर.
एक पेशंट आहे 43 वर्षाची फिमेल पेशंट आहे.
हा,
तिला TLD चालू आहे.
बर.
तर TLD घेतल्यानंतर नेझल ब्लिडिंग व्हायला त्याला आणि प्लेटलेट काउंट 24,000 झालाय मॅडम.
अच्छा.
आणि TLD घेतल्यानंतर तिला त्रास होतोय आणि TLD थांबवलं तर ते काही तिला त्रास होत नाही.
पण TLD थांबवल्यावर प्लेटलेट काउंट वाढला असं डॉक्युमेंट झालंय का सर?
तसं नाही, कमी झालेलं दाखवते परत. हा वाढलंय ते पहिलं एक वेळेस वाढलंय कमी झाल्यावर.
म्हणजे गोळी थांबल्यावर प्लेटलेट काउंट वाढला होता?
हा वाढलंय.
कारण काय आहे की जेव्हा आपण ड्रग इंड्यूस थ्रोम्बोसाइटोपेनिया किंवा असं लेबल करतो ना, बाकीचे काही कॉजेस रूल आउट करायला लागतात.
अच्छा अच्छा अच्छा.
तर तुम्ही एक त्याचं प्रॉपर ना हिमॅटॉलॉजी किंवा ऍटलिस्ट फिजिशियन रेफरन्स घ्या सर.
बर.
आणि मग त्यांचा सल्ला घ्या आणि ऍटलिस्ट काही बेसिक टेस्ट करू देत. म्हणजे लाईक SLE मध्ये थ्रोम्बोसाइटोपेनिया होईल, कधी कधी ITP असतं किंवा B12 डेफिशियन्सी असू शकेल, कधी कधी जस्ट रिसेंटली त्याला कुठलं ट्रॉपिकल फीवर, मलेरिया हे वगैरे झालेला असतो तो आपल्याला माहित नसतो, त्याच्यामुळे प्लेटलेट कमी आलेलं असतं. तर त्याचा सगळा आढावा घेऊन लेट देम असेस आणि मग स्टील म्हणजे सगळे बाकीचं काही रूल आउट झालं आणि ते स्ट्रॉंगली फील की ड्रग इंड्यूस्ड आहे, तर तुम्ही ससेप्ट रेफरल जरूर करा. किंवा तो पेशंट मग हायर सेंटरला पाठवा, JJ ला पाठवला तर आम्ही ऍडमिट करून इव्हॅल्युएट करूनही बघू शकतो.
ते प्रायव्हेटच्या डॉक्टरने सांगितलं पण मॅडम TLD मुळे आलंय तसं. तर
नाही, प्रायव्हेटचं नका सर, कारण प्रायव्हेट मध्ये ना ते थोडस कमर्शियल इंटरेस्ट असतात आणि मग ते तेवढी त्याचं कॉम्पिटन्स आहे की नाही आपण चेक नाही करू शकत. त्याच्या मेडिकल कॉलेजच्या मेडिसिन डिपार्टमेंट कडनं रेफरल घ्या.
ठीक आहे. किंवा
हिमॅटॉलॉजिस्ट कडनं हे करा. प्रायव्हेटचे असतील तर मग हिमॅटॉलॉजिस्टला रेफर करा ऍटलिस्ट.
ठीक आहे मॅम, थँक्यू मॅम.
हॅलो.
हा
मॅडम, डॉक्टर पाटील बोलतो कोल्हापूरवरून.
क्वेश्चन्स आहेत ना, हे आजच्या अडेरन्सच्या सेशनवर पर्टेनिंग असतील तर बरं पडेल. बाकीच्या इंडिव्हिज्युअल क्वेरीज तुम्ही विचारू शकता नंतर. हा, तुमचा व्हॉइस ब्रेक होतोय मॅडम.
सर तुमचा आवाज नाही येते बरोबर.
हॅलो.
हा बोला.
RD सेंटरवरून बोलतोय.
हा,
हॅलो,
हा बोला सर.
मालेगाव RDLS काउन्सिलर बोलतो मॅम.
हा
मॅम एक पेशंट आहे आमच्याकडे, 40 वर्षाची फिमेल आहे. व्हायरल लोड हा TND आलेला आहे.
बर.
तर मग ती आता मागे 2 महिन्यापूर्वी त्याचं गर्भपिशवीचं ऑपरेशन साठी ती प्रायव्हेटला गेली. तिथे त्याच्या स्टेटस अननोन होता, बट त्यांनी त्याची HIV ची टेस्ट केली. तर त्याची HIV ची टेस्ट निगेटिव्ह आली मॅम तिथे.
अच्छा. ओके. हे फिनॉमिनन असं रेअरली होऊ शकतं की पेशंट PLHI पॉझिटिव्ह असतो आणि मग जेव्हा त्यांचं व्हायरल लोड एकदम सप्रेस झालेलं असतं ना, तर कधी कधी अँटीबायोटिक टायटर कमी होतं त्यांचं आणि तसं होऊन मग कधी कधी निगेटिव्ह येऊ शकतं किंवा मग ते लॅब एरर होऊ शकतं. पण टेस्ट निगेटिव्ह आहे म्हणजे पेशंट क्युअर झाला HIVचा असं नाही येते. असे स्पेशली यंग पेशंट्स मध्ये आम्ही हे पाहिलंय फिनॉमिनन.
आणि त्या खाली ब्लड पडलं ते किती होते?
हॅलो
खूपच कमी होतं.
मॅडम, एक प्रश्न होता. डॉक्टर पाटील बोलतोय. मॅडम, TLD चालू केल्यानंतर काही पेशंट आता हिपॅटोटॉक्सिसिटी व्हायला लागलेली आहे, म्हणजे आमच्या नोटीस मध्ये आलेलं आहे असं.
हो, हिपॅटोटॉक्सिटी सर. हा, तर ते कसं आहे त्याच्यात पण
अशा पेशंटला मॅडम थोडे दिवस टायमिंग स्टॉप करून त्यांना हिपॅटिक टॉनिक वरी देऊन परत चालू करू शकतो ना आम्ही?
हा, तर त्याच्यामध्ये ना सर परत ते जे असेस करतो आपण हिपॅटोटॉक्सिटी आहे त्याच्यात मल्टिपल फॅक्टर्स असतात. म्हणजे माझ्या एक पेशंटच्या अनुभवावरनं मी सांगते की कधी कधी पेशंटला TBचं को इन्फेक्शन असतं आणि ATT मुळे पण TBच्या ड्रग्समुळे हिपॅटोटॉक्सिटी असते.
बरोबर.
आणि तिथे डबल डोस जातो DTGचा. तर TBचे ड्रग्स असतील तर पहिले TBचे ड्रग्स थांबून मग पेशंटचे LFT इम्प्रूव्ह होत आहेत का बघायचं. जर का पेशंटचे LFT इम्प्रूव्ह झाले तर मग ती TBची हिपॅटोटॉक्सिटी होती. मग काही दिवसांनी मग आपण रिइनिशिएट करू शकतो ATT. मग त्यावेळेला DTG मे नॉट बी स्टॉप. पण TBच्या गोळ्या थांबूनही जर का पेशंटचे LFTs कमी आले नाही आणि किंवा वाढले तर मग ते DTGचं असू शकतं. कारण आपण स्पेशली DTG डबल डोस देतोय. तर पहिले तुम्ही TBचे ड्रग्स बंद करून बघा आणि मग तरी नाही LFT हे झालं तर मग DTG थांबून LFT इम्प्रूव्ह होतात का बघायचं. दिस इज फॉर पेशंट्स वर ऑन AKT. सेकंडली, देर आर अदर कॉजेस ऑफ हिपॅटोटॉक्सिटी म्हणजे हिपॅटिक एन्झाइम इलेव्हेशन, लाईक पेशंट मे बी टेकिंग अल्कोहोल आणि त्यांनी तुम्हाला सांगितलं नसेल आणि अल्कोहोलिक हिपॅटायटिस. कारण असे पेशंट माझ्याकडे 2-3 असे पेशंट झाले की DTG टॉक्सिटी म्हणून रेफर झाले, पण ऍक्च्युअल पेशंटचं सगळं आम्ही इव्हॅल्युएट करायला गेलो होतो. त्यांनी मग अल्कोहोलची हिस्ट्री नंतर दिली आणि मग ते अल्कोहोल हिपॅटायटिस होतं.
बरोबर.
सो तिथे मग आम्ही तात्पुरती ART पण थांबवली, पण अल्कोहोलचं सगळं हे करून त्याचं बंद केल्यावर LFTs कमी झाले आणि मग DTG टॉलरेट झालं.
अच्छा.
त्यानंतर
म्हणजे आपण रिस्टार्ट करू शकतो मॅडम लेवल्स कमी झाले की?
लेवल्स कमी करून रिस्टार्ट करून बघायचं सर. रिस्टार्ट केल्यावर जर का परत LFT वाढले तर मग मात्र तुम्ही मग रेफरल करा.
बदलावं लागेल.
चेंजिंग.
चालेल मॅडम. थँक्यू मॅडम.
थँक्यू ऑल ऑफ यू.
हॅलो मॅडम, मी जळगाव ARTCची MO बोलते. मॅडम, TLD हॅलो. मॅडम, DTG इंड्युस्ड वेट गेन हा एक मेजर प्रॉब्लेम येतोय फॉर अधेरन्स, बिकॉज खूप सारे पेशंट सांगतात की आमचे वेट खूप वाढले तर गोळ्या चेंज करू शकतात का? मी आजच एक पेशंट बघितला, त्याचं 14 months मध्ये 18 किलो वजन वाढलंय आणि ही वॉज फिलिंग ब्रेथलेस आणि असं म्हणजे बिकॉज ऑफ द वेट गेन त्याला सिम्पटम्स येत होते. सो इव्हन तो त्यांचं पॉझिटिव्ह काउन्सिलिंग आम्ही केलं फॉर एक्सरसाइज डाएट वगैरे, पण ते रिलक्टंट आहेत आता गोळ्या घ्यायला. हा मेजर इश्यू आहे.
तर त्याच्यामध्ये पण पहिले आपण थोडस त्यांचं डाएट मध्ये काउन्सिलिंग करा, जसं तुम्ही ऑलरेडी केलंय म्हणताय. पण डाएट आणि एक्सरसाइजने हेल्प नाही झाले असेल आणि रिअली पेशंट जर का रिलक्टंट असेल आणि एवढं 18 kg वगैरे असेल तर मे बी देन वी नीड टू चेंज इन दिस केस. पण असं सगळ्याच पेशंटचं फक्त 4-5 किलोनी वाढलंय मग ते काय होतं, मग सगळं एकमेकांचं ते म्हणजे ते बघतात. तर हे जे आहेत ना अगदी एक्स्ट्रीम वेट गेनचे आहेत आणि मग त्याच्यामुळे ते रिलक्टंट असतील तर तिथे आपण चेंज करू शकतो, पण नॉट एव्हरी पेशंट.
मग असे पेशंट आम्ही सासेपला रेफर करायचे का मॅम?
हो, करू शकता तुम्ही, करू शकता.
ओके मॅम,
आणि मग ते आपण ऍक्च्युअल सेटअप मध्ये पेशंटशी थोडा डायलॉग करून आमच्याकडनं पण काही थोडंसं आम्ही काउन्सिलिंग वगैरे करून मग वी कॅन सॉर्ट आउट दॅट प्रॉब्लेम.
थँक्यू मॅम.
हॅलो मॅडम.
हा
Thank you, everyone. Requesting Praveen sir to share a e-poll with participants.
Is it visible, the e-poll?
Yes, sir.